Hi, I'm Christina Trependahl. I'm a family nurse practitioner from Mississippi, and I have a headache center there, and I mainly treat primary headache syndromes. That's 99% of my practice. So Dr. Roger Cady asked me to give a talk today, and I thought I'd be giving a talk on migraine, or one of the TACs, one of the primary headaches. And as you know, primary headaches don't generally kill people. They just destroy their quality of life. But Roger told me I was going to be giving a talk on secondary headaches. So when he told me that, I was kind of flustered because I don't treat secondary headaches for the most part in my clinic. And if you've ever seen Gone with the Wind, Prissy, one of the servants, was telling everybody that she knew how to deliver babies, but when it came down to it, she told Miss Scarlett she didn't know nothing about birthing no babies. So that's kind of how I felt when Dr. Cady asked me to give a talk on secondary headaches. But I've done a lot of homework, and so the objectives today will be to first keep our patients safe and keep our patients alive. We've got to get the diagnosis right to keep them alive. And then if you're planning to take a certification exam in headache medicine, the next goal would be to pass the test. All right. So what's the first step in making sure our patients are safe and that we keep them alive? And that is getting the correct diagnosis. So when you're diagnosing a headache patient, you're looking to see if the headache is a primary headache disorder or if it's a secondary headache. The way we do this is to take a detailed history and physical examination, and then you're going to be looking for certain red flags, and the acronym for that in headache medicine is SNOOP, and I'll show you that on the next slide. But you're going to be looking for red flags either in the history, what they've told you, or in the physical examination. If you do not find any red flags or worrisome features, then you can diagnose a primary headache syndrome. If you do notice red flags or something that's not quite right in the story or the picture or some neurologic deficits, then you'll want to investigate further with more diagnostic testing. Also, if you believe you have a primary headache type with no red flags, but you find some atypical features of that primary headache syndrome later on, or if you try them on conventional therapy and that treatment they're not responding to, then you might want to go back and revisit whether or not you've got really a primary headache disorder, or if you're missing a secondary headache disorder, and maybe run some more diagnostic tests. Okay, so SNOOP-5 is the acronym that's used by headache specialists to rule out red flags or worrisome features in headache. And you can get this through the history and the physical examination. You're screening for red flags. The first is the S, which stands for systemic features, such as fever and weight loss, or secondary risk factors, a history of HIV or cancer. And these will come up over and over throughout my talk. And today, if the only slide that you memorize or get to know very well, it should be this slide, the SNOOP slide. The next is the N for neurologic signs or symptoms. The first O is for abrupt onset thunderclap headaches. You'll see those in subarachnoid hemorrhage, cerebral venous sinus thrombosis, and cervical artery dissection. The next O is for older age. Patients greater than 40 can have a subarachnoid bleed. Greater than 50 can have giant cell arteritis. You can have glaucoma and cardiac cephalalgia, which is a heart attack that presents with a headache. Previous history of a headache, if a patient comes to you and they've had headaches all their life and they've been the same, that's great. That's a reassuring feature. But if a patient has a new onset headache or a change in the pattern, they say this is not like my other headaches, and that's worrisome, and you'll want to investigate further. So a change in the pattern if it's progressive, or if it's a new onset headache and they don't have a previous history. The next P is for postural changes. If the patient gets relief by either laying down or sitting up, you could have a CSF leak, or you could have increased intracranial hypertension. And the next P is any headache that might be precipitated by Valsalva or exertion, and that could signify a Chiari malformation or a space-occupying lesion, a mass, neoplasm. Also, pulsatile tinnitus. This is the swooshing tinnitus that some patients who have pseudotumor will report, and they also can have double vision and transient visual changes. And then the last one that was added most recently, it used to be SNP4, now it's SNP5, is pregnancy. There's lots of pathologic conditions that can happen with new onset headaches or headaches during pregnancy. And then the Y, my friend Ira Turner added for y'all have no idea what's going on. So that kind of goes back to you thought it was a primary headache, you're treating the primary headache, or there's some atypical features and we really don't know what's going on. You might want to run some more testing. So the next slide. This I got from Dr. David Dodick at the Mayo Clinic. This is his brief 5-minute evaluation of the headache patient. You'll want to check vital signs, especially the blood pressure and the temperature, because you're going to rule out infection. And blood pressure especially because we're going to give these patients some medications that could affect their blood pressure, and you'd want to screen for that. Also BMI, a lot of our patients are obese, and obesity will have higher risk factors. When you get to the head and neck exam, you'll want to palpate the extracranial nerves, the temporal mandibular joints, the temporal arteries, especially age 50 and above. You want to see if the arteries are tender, hardened, or there's a decreased pulsation. And then pericranial and paraspinal muscles, including the cervical and trapezius, and the paranasal sinuses. Now, Dr. Dodick says that you can do a brief neurologic exam. Dr. Alan Purdy and Dr. Ira Turner say you should do a 12 cranial nerve exam. The first thing you're going to do is you're talking to the patient. You can assess their mental status. The most important part of the visual part of the cranial nerves is the eye exam, getting a good fundoscopic exam, visual fields, and ocular motility. Those are paramount. And then you want to assess facial sensation, symmetry, the palate and the tongue. You're going to test the reflexes and the plantar response, and then you're going to watch them walk. Now, he put other down there at the bottom, but I would replace that with neck. So you always want to look for meningismal signs. So you want to check neck flexion, neck tenderness, neck stiffness, or rigidity. Okay, so I went one step further. This is where I wanted to go first. CT, if you go to a website called choosingwisely.org, they have recommendations from the American Academy of Radiology and the American Headache Society that says do not do CT except for in the emergency room condition for uncomplicated headaches. So CT cannot show us as much as MRI. It also exposes our patients to more radiation, and that can lead to cancer. The only situations that you would really want to perform a CT are in the emergency setting when you have suspect a subarachnoid hemorrhage, a stroke, or head trauma. But I did add here that sphenoid sinusitis can be detected on CT, especially if you're looking at the sinuses. And sphenoid sinusitis is a medical emergency. I had a patient that presented with what was seemingly a new onset cluster headache type, and he was a male of appropriate age, and he was not responding to cluster headache treatment. He'd been screened at the emergency room. He had a CT. He also had an MRA and an MRV, and when we weren't getting any improvement in him with our cluster medications, I sent him back for an MRI of his head, and we discovered that they had missed a sphenoid sinusitis. He was sent to surgery, and his issues resolved, so he did not have cluster headache. He just had a cluster presentation. So the MRI will show us a lot more than a CT will. So for any red flags in a headache patient, you'll probably want to do an MRI with and without contrast. You can see ischemia, posterior fossa lesions, cervicomedullary lesions, white matter abnormalities, and just remember that 12 to 46% of the patients who have migraine will have some scattered white matter lesions that sometimes are overread as MS. You can find subdural and epidural hematomas, meningeal disorders, cerebritis, brain abscess, pituitary lesions, neoplasms, and other mass lesions. And you'll especially want to get a scan if the patient presents with a headache that's brought on with exertion, call for Valsalva, and rule out Chiari malformation. Okay. And then labs, I took this from many different sources. The CBC, that's kind of routine. If a patient comes to me and they've had a recent CBC in the last year and there's no new onset headache, I'm not going to order labs, but a CBC is good to look at, and then also I do a comprehensive metabolic panel, because your liver function studies and your kidney studies are very important for the medications that you might put them on for prevention or attack. And also, I didn't realize this, but hypercalcemia can present with a headache as well. Also, I get lipid panels and A1Cs on any of my patients that are obese, not monitoring their health, not monitoring their blood pressure, not treating their diabetes well, because a lot of times we'll put patients on triptans and other things that we wouldn't want them to be taking too much of if they have a lot of cardiac risk factors. Also, the thyroid and B12 can affect the neurologic system, and you want to get a SED rate if a patient is suspect of giant cell arteritis over age 50. And then Dr. Ann Calhoun, she treats a lot of menstrual migraines, so sometimes she'll get a ferritin level and a folate. And then if a patient has a lot of arthralgias, you may want to get an RF, rheumatoid factor, and an ANA, and sometimes you can rule out lupus. If you have a young person, maybe a teenager, with sore throat and cervical swollen lymph nodes, then you may want to get a mono test to make sure that they don't have mono. If you have, if you're suspecting any infectious etiology, you want to get an HIV or a Lyme titer. And then if you're going to rule out cerebral venous sinus thrombosis, you can rule that out with a D-dimer. And then if you suspect any pituitary lesion, then you want to get a prolactin and a cortisol level. And then if you have any patients on any of these drugs that could cause toxicity, then you'll want to monitor their levels of those drugs. Some of our patients will have enough red flags that will want to get a lumbar puncture. So which patient would that be? The patient that presents with fever and a stiff neck, of course you're going to look for meningismal signs. And when you're evaluating the neck and looking for meningitis, look up the Brudinsky sign and do that test. It's a really good test for neck pain and neck stiffness with meningitis, Brudinsky. Also, if a patient has an altered mental status or motor or sensory deficits, changes in behavior or personality, speech and movement disorders, cranial nerve palsies, seizures, papilledema, first or worst headache of my life, any atypical features that don't really fit into a primary headache disorder, and any patient that you would suspect having a CSF pressure change, high or low pressure headaches. And the LP can diagnose subarachnoid hemorrhage, high and low pressure headaches, meningitis, especially cryptococcal meningitis, encephalitis, meningeal carcinomatosis, and lymphomatosis. I didn't always do this, but every time I get an LP, I'll always ask them to look for the cryptococcal antigen, because that can typically present as either a tension type headache or a migraine type headache. And also remember to remind the radiologist or the neurologist that's doing the LP to always get an opening pressure in the lateral decubitus position. The position is very important for that number. And this is our first pathologic secondary headache that I'm going to review. Subarachnoid hemorrhage. Nearly 2% of the population harbor intracranial aneurysms. And the rupture of those can lead to devastating neurologic impairment or death. So we don't want to miss that. These usually do present in an emergency room because the patient usually has a severe thunderclap headache. A ruptured aneurysm is at risk of rebleeding. They are amenable to surgical repair. And the good news is if you're diagnosed while neurologically intact, you're most likely to be discharged neurologically intact. And I got this from Dr. Alan Purdy. He said, beware blood in the pits. And that acronym is for blood in the parenchymal, intraventricular, truncal, and sulcal. And like I said, this has an abrupt onset headache or a thunderclap headache. Many describe it as a WOML, which I call the worst headache of my life. That's the acronym for worst headache of my life. The risk factors: age greater than 40 years of age, neck pain or stiffness, and limited neck flexion on exam. Try that Brudinsky sign. witness loss of consciousness. Syncope with headache is always a bad thing. And then onset during exertion, and like I said, it's a thunderclap headache. So the next secondary headache we're going to talk about is traumatic head injury. Following head trauma, if you see altered mental status or focal neurologic deficits, this may signal an intracranial hemorrhage. The most common hemorrhages after head injury are epidural and subdural hematomas. They're less likely to be subarachnoid hemorrhage, and they are amenable to surgical intervention as well. The older the age or the use of coagulation and antiplatelet agents will increase your risk, so you'll want to have prolonged observation in the hospital. Also, a persistent abnormal Glasgow Coma scale will signify worse brain injury. A normal GCS will result most likely in post-concussive syndrome. This includes headaches, dizziness, memory disturbances, and alterations in mood or personality. The next bad thing I'm going to talk about is brain tumor. Everybody who comes to the headache specialist asks if they have a brain tumor. Don't scan everybody. This is very important. A lot of our patients are women, and women have migraine 3 to 1 over men. But remember, a lot of our patients have had a history of breast cancer. So if they have a history of cancer or a history of HIV, they can have metastatic brain tumors. And the METs of non-CSF origin are much more common than primary CNS tumors. Focal headaches may be related to the tumor location. Generalized headaches are usually because of increased intracranial pressure. And this is significant. Progressive severe headaches that worsen upon awakening and are associated with nausea and vomiting. And what's so concerning about that is that's how a lot of our migraine patients present. I think 50% of people who have migraine report morning headaches. So anytime you see morning headaches with nausea and vomiting and it's getting progressively worse, you want to think, could my migraine patient actually have a brain tumor? So any change in pattern, anything that's new, and especially that morning headache that presents with nausea and vomiting. And like I said, it can be variable in character. It mimics tension type headache or migraine. It can be intermittent, moderate intensity, resolve within hours, and not have a specific location. All right, the next slide is giant cell arteritis, also called temporal arteritis. This is a disorder that happens to the elderly. It's a new onset headache in the elderly, or a new type of headache in people that are 50 years old or older. The peak age for this is 70 years old. It is a systemic large vessel vasculitis that affects the carotid and vertebral arteries. Headache is the most common symptom. Other symptoms include fatigue, weight loss, fever, scalp tenderness, jaw claudication, aching neck and shoulders. The bad sequela of this is that you can lose your vision or have an ischemic stroke, so we don't want that to happen. If your patient has headache and visual symptoms and is greater than 50 and you suspect GCA, you should start corticosteroids immediately rather than waiting for a biopsy confirmation. And the criteria is 3 out of 5, age greater than or equal to 50 years of age, new onset type of headache, or new onset or new type of headache, change in pattern, temporal artery tenderness or decreased pulsation, SED rate greater than 50, and an abnormal biopsy. Cerebral venous sinus thrombosis. This is one that terrifies me because it can happen in children. It occurs when a blood clot forms in the brain, and basically it's part of a stroke, and it can occur in adults and children. 3 out of 300,000 children up to age 18 will have a stroke. But if you look down at the bottom, the children have risk factors down here. Sickle cell anemia, chronic hemolytic anemia, beta thalassemia major, heart disease, iron deficiency, certain infections, dehydration, and head injury. This is a lethal condition. Sometimes you can present with subtle symptoms such as headache or blurred vision, and sometimes there are not so subtle symptoms. Like I said, headache with syncope is always bad. So if you have a patient that's witness syncope or witness falling out with a headache, make sure you do a further investigation. Also, loss of control over a body part, seizures, and coma. There's lots of thrombolytic risk factors. The main one I'm going to point out is pregnancy and postpartum. And this can present, I believe, with a thunderclap headache, yes. And then cavernous sinus thrombosis is in the eye, and it's much more overt in presentation. You'll see proptosis, facial edema, ocular palsies, and visual deficits. Cervical artery dissection. Think of this, ladies, when you're going to get your hair done, when you're going to get your roots dyed or your hair trimmed. Anytime that you lay your head in that bowl, you could have a spontaneous cervical artery dissection. It occurs with tears in the arterial wall that form intramural hematomas and obstruct blood flow and cause stenosis and aneurysmal dilation. It can be spontaneous or traumatic. Traumatic is with hyperextension or rotation of the neck, and this has been known to happen at the salon when people have their head in the bowl. Vertebral artery dissection can happen with chiropractic manipulation. It can be precipitated by coughing, vomiting, and heavy lifting. And the classic presentation is headache, neck pain, and signs of brain ischemia. Carotid artery dissection is more common, and they're more likely to present with a headache first before neurologic findings, whereas the vertebral artery dissection usually presents with neurologic symptoms before the headache. But they can have an occipital headache and neck pain, vertigo, nausea, vomiting, and facial numbness, and an unsteady gait. Meningitis is a constellation of signs and symptoms with a nonspecific headache. Usually presents with fever, neck stiffness, and altered mental status. Remember the Brudzinski sign. Sharp, sudden head movements can make the headache worsen. Cryptococcal meningitis is significant for patients that present with headache because it mimics tension-type headache, and it's typically happening in the immunocompromised patients. So that's when we go back to getting that history of HIV. And progression can cause elevated intracranial pressure, alterations in consciousness, papilledema, cranial nerve palsies, and seizures. The next disorder I'm going to talk about is pituitary apoplexy. This is very rare, which is good. Usually these patients have a history of pituitary adenoma, but sometimes the headache, with the apoplectic headache, is often the first sign or symptom of the adenoma. You'll see with this ophthalmoplegia, which is paresis of one of the eye movements, visual field deficits, hormonal collapse, and thunderclap headaches. This is another one that has thunderclap headaches and it has the risk factor of recently having a baby. So pituitary apoplexy, I want you to think of thunderclap headaches and somebody who's recently had a child. The next one is stroke. Hemorrhagic stroke usually presents with a severe abrupt headache, whereas ischemic stroke typically presents with neurologic deficits. So if somebody presents and they're neurologically intact, they're probably not having an ischemic stroke. Only 1 in 4 will report a headache with acute ischemic cerebral vascular disease, and the headache is more common in ischemic stroke if the patients are younger and have a history of migraine. This is RCVS, which is reversible cerebral vasoconstriction syndrome. This is another one that can happen with pregnant women, and it presents with repetitive thunderclap headaches that last anywhere from 2 to 12 weeks. And you can also have focal neurologic deficits, visual disturbances, hemiplegia, ataxia, dysarthria, aphasia, and numbness, and seizures. It is self-limiting, but if you look at the bottom, the complications are stroke, cerebral edema, and death. The treatment is verapamil or nimodipine, and this is best diagnosed with catheter angiography, but you can also get a CTA or an MRA. This is underdiagnosed, and this can also happen with people who use vasoactive drugs, including cocaine. So think childbirth, pregnancy, and cocaine, RCVS. thunderclap headache. And pseudotumor cerebri, now called idiopathic intracranial hypertension. This is the secondary headache that I would say I treat most in my clinic. Most of our patients are obese. So this happens in obese women of childbearing age. Actually, all my patients who are new to me go to the ophthalmologist to rule out pseudotumor with visual field testing and fundoscopic exam. So there's generalized brain edema with subsequent elevated CSF pressure. The headache is the predominant feature, and like I told you before, you can ask them about pulsatile tinnitus. Do they feel tinnitus that has a pulsating beat to it? And 6 nerve palsy. The headache mimics migraine in that it can be throbbing with nausea and vomiting. Typically, you need to ask the patient about postural changes. That was one of the P's in SNOOP. It usually gets worse when they're laying supine. A lot of these people will say they have to sleep sitting up. Visual findings, they can have double vision. And when I talk about the eye later on, you'll see that double vision is always a bad thing. You always want to work up double vision. And they can have transient visual obscurations and papilledema, which is swelling of the optic nerve. So that's why the fundoscopic exam is so important. So you'll want to get them visual field testing. You can watch on YouTube for some confrontational visual field testing demos. You want to look at the optic nerve to see the extent of the damage and also their response to treatment. An MRI is required to rule out many other things that could cause the intracranial hypertension. The MRV is necessary to rule out venous sinus thrombosis that can also mimic pseudotumor cerebri. And the opening pressure is usually greater than 25 centimeters or 250 millimeters in obese women. And they do not recommend that you get repeated LPs. LPs can cause lots of bad things, especially low pressure headaches and infection. Treatment is aimed at prevention of vision loss. So hopefully the first 3 would work, either Diamox, Lasix, or weight reduction of 3%. Rarely these patients will need ventricular shunting or optic nerve sheath fenestration. Okay, and I'm just going to touch on this low pressure headache briefly, spontaneous intracranial hypotension, and I got this from Dr. Alan Purdy. His mnemonic, his acronym is SEEPS. You'll see on the scan, the MRI, subdural fluid collection, enhancement of the meninges, engorgement of the veins, pituitary hyperemia, and sagging of the brain. And this can happen more so in patients who have hypermobile joints. And this is called CADASIL, which stands for cerebral autosomal dominant arteriopathy with subcortical infarction and leukoencephalopathy. I don't want to have to say that again. It is a mutation in the Notch3 gene on chromosome 19. This is a familial disorder, so the history is really important. You want to find out if anybody in the family has a history of migraine, especially migraine with aura, an early onset stroke, strokes before age 60, and early onset dementia. This runs in families. This is another rare syndrome called Handel. It's headache with neurological deficits and cerebrospinal fluid lymphocytosis. It is a self-limiting viral illness. It's common in age 30 to 40 years of age, but it can affect children. The attacks last about 2 to 3 days. The symptoms include fever and symptoms of viral illness followed by headache. It's more common in men, and you may see some neurologic symptoms such as sensory aphasia, motor deficits, and unusual visual phenomena. You have to rule out viral encephalitis, neoplastic and granulomatosis disorders, HIV, neurosyphilis, and neurobrucellosis. SMART syndrome. This happens to people who've had radiation for a brain tumor about 2 to 10 years ago. So out of that SMART, just think of the R stands for radiation, and they have a history of brain tumor in the past. Cardiac cephalalgia. I got this from Dr. Alan Purdy at a a talk that he did once. I did not know this, but 3.5% of patients who are presenting with a heart attack complain as headache as the primary symptom. It's usually a headache in the facial region and the anterior neck. So think of somebody presents with pain in the head or neck over age 50, they could actually have a cardiac etiology going on rather than what we'd say is a headache or a brain abnormality. So these people have a new onset headache after age 50. The headache can be exertional and they have cardiac risk factors. Okay. Now, when I read this book, so this is the book that I read and studied intensely for the CAQ exam. It's called Headache and Migraine Biology and Management. It's a very good book. But when I read the chapter about headache in the eye, I was terrified. And this is how I felt. Some of the things that you can study in there can really make you think, maybe I'm missing something. So if somebody has any sort of eye pain or double vision, please get them checked out by an ophthalmologist or a neuro-ophthalmologist. Some things that I found, this is a cavernous sinus thrombosis. So the veins are not draining, and so that you see the proptosis. And then this is glaucoma. And the next one is herpes zoster, right on the eye, which is shingles. So these are some bad things that can go on if the patient has any visual problems, pain in the eye or double vision, then you really want to check it out. They can have cerebral sinus venous thrombosis, the cavernous sinus fistula that I just showed you, pseudotumor cerebri, papilledema, and many more that I have listed on this slide: orbital apex syndrome, thyroid eye disease, cortical stroke, and uveo-meningitic syndromes. So if the patient presents with either acute vision loss or double vision, this is and a headache, this is an emergency. So you'll want to rule out giant cell arteritis, pituitary apoplexy, aneurysmal rupture, meningitis, acute angle glaucoma, carotid dissection, orbital infection, and third nerve palsy. And this is my last slide. Like I said, double vision or diplopia is always a bad thing with headache and the eye pain. So there's a lot of things you have to rule out if somebody has diplopia. You want to rule out orbital inflammatory syndrome, Tolosa-Hunt syndrome, trochleitis, giant cell arteritis, neoplasms, infectious etiology, third, fourth, or sixth nerve palsies, thyroid eye disease, aneurysm, and trauma. So that is all of my presentation, and here are my references. Thank you very much.